Hello, I'm Catherine Gilliss. I am the Dean of the UCSF School of Nursing, and I'm pleased to be here today as part of the Under the Microscope series, where we're featuring UCSF alumni on their perspectives on health and health science. Each month, Under the Microscope will feature a UCSF Dean and in conversation with an alumnus. Each conversation will be 20 to 30 minutes in length and will address trending issues in healthcare or a topic related to health sciences. Today, we are in the company of my colleague and our alumna, Gina Shuler. Gina is the UCSF Associate Dean for Clinical Affairs in the School of Nursing and the Vice President of the Office of Population Health, and the Accountable Care Organization at UCSF. Gina is an alumna of the School of Nursing. She earned her master's degree and then a PhD in health policy. She's held several roles at UCSF, has a deep clinical background, including the delivery of critical care to patients in the ICU, and she served as Director for Clinical Operations in the cardiothoracic surgery area for a number of years. Currently, again, she's the Director of Population Health at UCSF. She is the Population Health Officer at UCSF, and I might add, one of the very few in the country who is not a physician. Gina is a registered nurse. So I want to ask you to begin with, how did your time as a student at UCSF support and influence your career aspirations?
Okay, thank you, Dean Gilliss, for having me here. I'm very honored to have been chosen for this Under the Microscope interview, and very appreciative of everything, all the experiences that I've had at UCSF. As you mentioned before, I have been a bedside clinical nurse. I then moved into surgical care, where I was able to start to understand the continuity of care for patients. And then that is when I pursued my graduate studies as a student at UCSF. And I think what was most impactful for me was the intersection of an event that happened with me with a patient, and then the consequent meeting I had with who later became my advisor, Ruth Malone. So I have always been troubled by the fact that most of healthcare is at the end of chronic disease, especially acute care and in the ICU. And I always felt one thing that made it really clear to me was a particular patient. So it's important for me to tell this story because it really did change the way that I look at patient care and really set the tone for my career and then what studies I pursued at the School of Nursing. And I think it's important to note. So I was taking care of a young man. He was about 42 years old, who had had pretty massive heart attack, was really sick in the ICU, and then needed consequent surgery. We did surgery on him, and he recovered. It took him a while to recover. He was a 3-pack-a-day smoker, and at that point, I was on the cardiothoracic surgical service, managing patients through their continuum of care. And we saw this patient about 3 weeks later, after he had been discharged and recovered. And I remember walking into the exam room to see him, to do an assessment before he saw the surgeon for his follow-up care. And immediately noted, obviously he had resumed smoking. And it just occurred to me at that time, I thought to myself, which many healthcare workers do, is like, that's not a really good choice. How could he possibly do that? He just went through this surgery. And, and I felt that way. And then, I took care of him and kind of went on my way. About 2 weeks later, I learned that he passed away. He had gotten a special kind of arterial grafting that was particularly susceptible to spasm, especially when you smoke, even though we gave him meds to prevent that. And at that point, when I found out that he passed away, I was very concerned that all the time he spent in the hospital and all the things that we do in acute care are really because that we don't have we didn't have the kind of infrastructure we need in healthcare in the United States to prevent that from happening in the first place. And that the whole time this patient was here, we addressed everything, but the thing that eventually killed him was his smoking. And it wasn't so much that I was aware of, the tobacco industry or anything like that. I just recognized that that seemed really incongruent with being a healthcare provider, that we didn't make the time or provide the resources to really help this man with something that was so critical to his survival, and he died from it, even though he went through a harrowing experience. It was at that point I knew that I didn't want to pursue more clinical studies. I didn't want to become a nurse practitioner. I didn't want to become a clinical nurse specialist. I had been interested in genomics, and we had offered a genomics program at the time. And what really appealed to me was this idea of getting involved at the level that is much more upstream for healthcare. So I pursued the health policy program, which was new at the time and was really a fit for my personality, but also for the sort of social justice that I think is so important and missing in healthcare, because we have really rallied around fixing, which I think is an important thing. If you think about the arc of healthcare, is that we've been for the last 100 years really focusing on taking care of acute illness. And I think at this time, and so in school, what I learned so much, and I use every day, both through my graduate and PhD programs, was the intersection between policy and healthcare, how often that doesn't get to the end of the line in the way that it was originally envisioned due to a lot of different forces. And I think just recently, how much social justice plays into the fact that much of healthcare, a lot of the healthcare outcomes that we see is based on social injustice. And I think that is a great awakening that healthcare is having right now and is going to be key to the future. Some of my favorite courses in my graduate program were, theories of organizational analysis. It's so funny. I just told somebody I use what I learned in that course every single day when I see how organizations are structured and behave, and I try to alter them or get around them. But because I understand them, I understand why they're happening. And then the other parts of it that were so important is the epidemiological principles and nursing advocacy. And the fact that nurses have, in my opinion, been too far from the decision-making tables. And I learned a lot about having a voice and making sure that people understand that we bring a unique and very well-informed perspective to all aspects of healthcare, because nurses work in all aspects of healthcare.
Well, Gina, that explanation seems to lead me right into a better understanding of why you are someone who's now in population healthcare.
Mm-hmm.
Current position in population healthcare, how do you address issues of social justice and improvements that are policy related?
Mm-hmm. So I would say there's a couple of things that happened both historically and recently. So first of all, California is a very progressive state, and my first foray into population health was through the creation of the Affordable Care Act. California was being prepared to start delivering care through its safety net system using population health principles, meaning that safety net systems were getting incentivized to put structures in place that would address complexity, population health level outcomes, preparing us for what we thought would be the eventual transition. I still think it'll happen, but it's on a little bit longer of a timeline of moving us from fee-for-service to value-based care. And when I took this role, the focus was on, even in California, we're lucky that everyone is insured under our Medi-Cal, our Medi-Cal structure. And so one of the things that really was an eye-opener was the fact that California was leading the way to create an infrastructure across the state to ensure that we were ready to manage populations That also coincided with the rapid implementation of really sophisticated electronic medical records, which also gave us the ability to have significant data architecture to be able to measure both the state of a population's health, and then also, at least in our own health systems, and then also the outcomes for the interventions that we would put to those populations so that we could see improvements. Because this was my first in those early days, what I also became really clear to me in those early days was just how different, depending on the insurance that you had, which often is a proxy for your socioeconomic status, was how different the outcomes were and how different the access was based on just your payer type. And everybody, and people may not know that, and certainly at the front lines, we may not think that we treat people differently, but I think the other thing that has been really clear as we become more sophisticated and more experienced with this work is that there are deep internal and industrialized biases that we have against populations as a healthcare system that are now being uncovered, and there's an imperative to address them. So I think that what I learned, and in fact, my boss is the Chief Clinical Officer, Dr. Josh Adler. And one of the reasons that I was able to even have the opportunity to be the Chief Population Health Officer was because I was PhD prepared in health policy, and that I was a clinician and had significant experience both in acute care, in the transitional care that I experienced with all of my surgical patients in that continuity model. And then also all the work that I did with primary care really opened my eyes. So I will say that the policy program, while at the time it felt like a gamble because I wasn't leaving with a clinical specialist, I wasn't leaving with sort of an extra certification as a nurse. I feel like it was the perfect fit for my personality and where circumstances had led me, and where I think my true passion lies is this idea of correcting things at a much higher level upstream.
I think Ruth Malone, your advisor, would be very proud. I'm sure she is very proud.
Mm-hmm.
She is now, of course, a member of our emerita community. I know that she's also an extraordinary scientist, and you are a bit of a data maven yourself. Are you able to help our listeners today understand the connection between your clinical concerns about population health and its policy and the kind of data that informs your work as a population health officer? Maybe there are some examples.
Yeah, so I think, first of all, like I said, we've become very sophisticated very rapidly in big data sets. So on a regular basis, my team looks at data for hundreds of thousands of patients. We benchmark internally. There's a very active population health collaborative across the 5 UCs. And so we benchmark internally across the 5 UCs. We're actually able to look at our outcomes as a UC system when we look at chronic disease or access or utilization around certain populations. And then I think one of the major roles of health systems, now that we have this level of sophistication and insight into our patient populations, and by no means have we completely understood everything that's happening with our patient populations, but I do think that it's an opportunity for us to really make those links with our communities. So one of the things that, as I said, the program, the DISRIT program, or the waiver program that's happening at the state, one of the things the state has that they've never had before is all the health systems reporting in the same health outcome data for 23 hospital systems across the state of California, and we're one of the biggest states in the union. So we have very robust data on the state of our populations that we serve in our health systems. So one of the things that I can say where is I think a real growth field for nursing, because certainly it's a growth field for medicine. There are tons of big data scientists, but again, I think nurses bring a very different insight into the data that has yet to be uncovered. And so, in my, just this past year, I also took the role as the Associate Chief Nursing Officer for Nursing Excellence. And one of the things that I hope to do is use all of the time that nurses spend documenting in this system. We should certainly be getting a lot more out of it to be able to morph our practice. So for example, some of the vision that we have for using data, I think of data in two ways. One is it helps us measure big outcomes. It helps us measure processes, but it also helps us cohort what I call operational analytics, where we can use data to understand how do we engage and identify the most at-risk populations so that we can take our really fast-paced, very resource-intensive environment or resource-needed environment. Sometimes it's not as intensive as we think it needs to be as our patients become more complex, and marry those up so that we can be proactively identifying issues before they happen and get our experts in there or our nurses in there to help, as opposed to what I call now is the electron theory of nursing, where a lot of, at least from the team of clinical nurse specialists and people who are this added layer of support for nurses, where we are often reactive. Something happens and then we react to our patients. So how do we back that up so that thing doesn't happen in the first place? So one of my most gratifying experiences doing this has been in the early days of DISRIP. My team helped implement an early warning system for sepsis and for pediatric deterioration. So through this program, we were able to have the resources to build that kind of infrastructure. And I think that how nurses can leverage that is really amazing. So we were able to identify patients before they went into septic shock so that we could get them all of the interventions needed so that they would not have an untoward outcome.
I appreciate your going through that for us and giving us the detail that you provided. I think for much of we're talking to our alumni community, and they are fairly sophisticated in health and health services and health sciences. But for much of the public, there is a limited understanding of what nursing science is. And I think you've given us some good illustrations about the goals of nursing, certainly to improve patient care. And there are many ways in which to do it, including with large data sets. We do have a strong program and a program from which obviously we've produced a very fine graduate. I know that many people would like to claim you as their own. And this year, as you've been the Associate Dean for Clinical Affairs in the School of Nursing, you've also been asked to step up and help to address some of the new work that we faced as the pandemic swept over the country. And we're very proud of the way that our campus in particular responded both in care delivery and in the development of science and resources for managing the pandemic. In your work as basically an administrator on the campus, a population health administrator, can you tell us a little bit about how you were involved in changing care during the pandemic and some of your insights maybe that are at a policy level?
Mm-hmm. Yeah, I think we've learned a lot. I think the pandemic, while it's a horrible thing to have happened and have that amount of people suffer, I think it also taught healthcare a lot of really valuable lessons. I think my biggest, so first of all, my involvement was in the early stages when it became clear that COVID was rapidly spreading. We used our population health team. We basically shut down the Office of Population Health from doing our regular work, and we pivoted to being a centralized resource and a hotline for assessing patients, triaging them and getting them to the right level of care quickly so that our emergency room was not overwhelmed. And people were in those early days, if you remember, even access to testing was difficult. So we set up systems quickly to be able to rectify that. Then it became really clear that our healthcare worker community was not immune to this pandemic. So we applied those same principles that we had for our patients to our employees, and we partnered with the Occupational Health Office to bring a very different working model, which was really about algorithms and standard work and escalation procedures to be able to quickly systematize the ability for us to meet the needs of our healthcare system, which was making sure our healthcare workers, our entire campus, not just our healthcare, but we're complete, as everyone may know, we're a health services campus. So, but being able to mobilize so that we had the ability to keep our employees safe and also keep them so that they could be on the front lines delivering care. So those were the early days of that. And that was really hard work. Then once the vaccine became available, which was very short notice that it was becoming available, we had to put up mass vaccination sites. We had never had to do anything like this. And the anxiety level of how desperate people felt to get the vaccine. And then on top of it, again, using data skills, we had to look at our employee database. And actually, if you remember, we had to categorize people into who was going to get it first. And so I feel really proud of UCSF's response to that, because we made sure that equity was front and center. In fact, our first employee to get the vaccine was one of the workers from our hospitality group that had took care of linens and laundry for our patients, and was just at risk as anybody would be a clinician taking care of patients. So I feel like UCSF did a very fair and equitable process for distributing the vaccines. It was a really big undertaking. And also because the vaccine technically itself was really difficult to administer, it required a lot of special handling, inventory control, observation, et cetera, because it was brand new. So those two things I still manage with a team. I certainly don't do it alone, and very grateful for, my partners, the chief innovation officer and the chief faculty practice officer and the chief pharmacy executive. So the four of us, along with many others, have been managing that response. I think the other thing that became really clear is, I think healthcare's overdependence on digital tools and digital communications. So one of the things that was very surprising, and I think was a lesson learned, was that there is, if we think of equity, one is people's access and ability to use digital tools. So we had real issues with some of our employees and patients having access to the vaccine because we live in an increasingly digital world, yet there are big swaths of people that haven't adopted the technology or don't have access or don't have the facility with the technology. And I think a lesson learned was to ensure that we always have multi-pronged strategies so that we can ensure that everybody has equitable access to whatever healthcare. And I think that lesson then translated into everything else that we do. We learned that in a big way with vaccine, and that is really informing the way that we do the rest of our care now.
Gina, your answers to these questions and the earlier questions, I think, give us a good give us a good sense of what the future of healthcare could look like. It is not surprising that a graduate of our program who focused on policy would have such command of the big picture. And clearly, the big picture can have a big impact and bring a lot of value to the delivery of high quality healthcare. Your career is also a perfect example of the importance of producing clinician scientists. We are proud of you as an alumna, and I'm very, very pleased that you are still an active and highly productive member of the UCSF campus community. I want to thank you for being here with us today. And I also want to thank our alumni who have tuned in. We appreciate so much your interest in our campus and your support of our work.